Bismillahir Rahmanir Rahim. So we will start with the day. Start with quote of the day. Faskuruni askurkum. So remember me, and I will remember you. This is from Surah Al-Baqarah in Quran. I am Dr. Taimia Ayub, and today I will be presenting the topic of HIV and AIDS under the kind supervision of Professor Dr. Saira Afzal, Dean, Institute of Public Health, Lahore. These are the learning outcomes of today's lecture. We will start with introduction, epidemiological factors, chain of transmission, clinical manifestation, diagnosis, management, and then we will apply levels of prevention, followed by we will discuss burden of disease, recent advances, and at the end we will do multiple choice questions. This is the learning outcome for today's presentation. So we will start with the introduction. HIV or human immunodeficiency virus is a retrovirus that infects CD4 plus T lymphocytes, leading to progressive immunodeficiency. Untreated HIV progresses to AIDS, acquired immunodeficiency syndrome. HIV has two types, HIV-1 most common and HIV-2 less virulent, present in West Africa. We will discuss them in more detail in later slides. Incubation period can be from months to years. Transmission occurs through unprotected sexual contact, contaminated needle, infected blood products, and mother to child transmission. So we will start with the timeline of the HIV. It started in 1900 is the first time when in Central Asia HIV virus origin is traced back to in particularly in monkeys, and then we can see in 1959 is the earliest known case of HIV. The first trace is goes back to the Central Africa, and then in America is the earlier cases were detected. And in then 1981, first aid case was discovered by the CDC in USA. And then in 1983, HIV virus was identified. In 1996, HEART is which is the therapy which was to treat or to manage HIV. It was introduced in 2003. Another PEPFAR, it was launched, and in 2010, PrEP and TASP, more therapies for HIV, they were scaled up. And in 2020, we have modern art therapy. So, what are the epidemiological determinants? We have agent factors, which is the lentivirus, which is a retrovirus, and then it targets CD4 positive cells, leading to progressive immune suppression. There are two main types of HIV. HIV-1, the most common type worldwide, it causes the vast majority of HIV infections. Then we have it is more aggressive and easily transmitted. Then we have HIV-2, mainly found in West Africa. It is less infectious and progression to AIDS is slower. And on the right side, we have a side-by-side comparison on the structure of HIV-1 and HIV-2 virus. And as you can see, there are some points in which they are different, and these are the ones which are highlighted in the diagram. So there are few differences which is present in the both the virus, and it results in different nature of these viruses. Then we come to the host factors. It can include any age. Adolescent and young adults are mostly affected. Sex, higher prevalence in male globally, increasing among female also. Immunity, no natural immunity. And art restores immune function. Environmental and social factors, poverty, low education, stigma and discrimination, unsafe sexual practices, drug use and needle sharing, migration, and high risk occupational exposure. So now we have the chain of transmission. Reservoir is humans, source is infected individuals, symptomatic or asymptomatic or carriers. Portal of exit is from blood, semen, vaginal secretion, or breast milk. Mode of transmission can be sexual, parental, vertical, and host susceptibility if the host is unvaccinated and no natural immunity. Mode of transmission, as explained, it is by the sexual contact, is the most common worldwide. by exposure is through transfusion, unsafe injection practices, shared needles. Mother to child transmission is during pregnancy or childbirth or even breastfeeding. Occupational exposure is by needle stick injuries. It is not spread by casual contact, food, water, or insects. So now we will define the cases and how do we define different terms related to HIV and AIDS. So, what is a suspected case? Symptoms suggestive of HIV, like chronic fever, weight loss, recurrent infections, and history of exposure, like unprotected sex or needle sharing with with HIV with AIDS individual. Probable cases: HIV antibody test reactive ones, or strong clinical features plus epidemiological link. Confirmed case is the one with two positive antibody tests using different assays or HIV viral load PCR detected. So, WHO case definition for HIV infection is: HIV infection is confirmed when any of the following criteria are met: positive HIV antibody test plus a confirmatory test using a different assay, detectable HIV RNA or DNA on nucleic acid testing like PCR, detection of HIV P24 antigen confirmed by supplemental test, and this applies to adults, adolescents, and children. And WHO case definition for adults: AIDS is defined as confirmed HIV infection plus any WHO clinical stage 4 condition. And we will explain these conditions now. So there are four stages of clinical stages of HIV or AIDS. Stage one is the one in which there is the person is usually asymptomatic, no symptoms of HIV disease. There might be some non-descriptive symptoms like short flu-like illness occurs 1 to 6 weeks after infection. Infected person can infect other persons. Then we come to stage two, in which there are mild symptoms. It can last for many years, like even the average is 10 years. It includes mild symptoms, HIV in blood drops to very low level. Antibodies are detectable in the blood. Then we have stage 3, advanced symptoms. In this, the immune system deteriorates, opportunistic infections can start to appear. And then finally, we have the stage 4, in which there are severe symptoms, or we call the stage AIDS, in which the syndrome is actually present and there is rapid decline in the number of CD4 plus T cells. Opportunistic infections become severe and cancer may develop. Now we come to the clinical features. Acute HIV infection, there are flu-like illness, fever, rash, myalgias, lymphadenopathy occurs 2 to 4 weeks after infection. Chronic asymptomatic phase, last year's persistent generalized lymphadenopathy is present. So this is how HIV infection affects the body. As you can see there, it can start from fatigue, sore throat, diarrhea, night sweats, muscle aches, rash, fever and chills, swollen lymph nodes, and mouth sores. And in advanced stage, which we call as AIDS, there is CD4 count less than 200 cells per microliter. Opportunistic infections like tuberculosis, PCP pneumonia, candidiasis are there, and AIDS defining condition like Kaposi sarcoma and lymphoma are there. And then at the end, we have wasting syndrome. Wasting syndrome is a condition specifically linked to AIDS disorder, in which the patient's muscles and generalized body is very much wasted, and the muscle mass has decreased a lot. So the for opportunistic infections, you can see they can occur at any place on the body. For eyes, the like cytomegalovirus retinitis can occur, microsporidiosis, ocular syphilis. And in brain, cryptococcal meningitis and toxoplasmosis. For skin, we can have mpox, varicella zoster virus disease like chickenpox and shingles. For liver, we can have hepatitis B virus infection, hepatitis C virus infection, and reproductive system can have genital herpes, HPV disease, genital warts, cervical cancer, syphilis, vaginal candidiasis, yeast infection. And similarly, for stomach and digestive system, cryptosporiosis can occur. HPV same can occur. Mycobacterium, avian complex disease can occur. Lungs can have infections like histoplasmosis, pneumocystis pneumonia, or tuberculosis. So I can do diagnosis is done using a stepwise testing strategy recommended by WHO and different national guidelines. So, number one, we can have screening tests, which are the initial tests. These detect HIV antibodies and or P24 antigen. These include rapid diagnostic checks, which include finger prick or whole blood test. Results can come in 15 to 20 minutes and used widely in clinics and ANCs and such centers. Then we can have ELISA or fourth generation combo test, which can detect HIV antibodies plus P24 antigen. It can identify infection earlier, 2 to 6 weeks post exposure. ELISA can tell us about the status of the individual. So on the right side, the figure is also showing us rapid point of care, standard point of care, and then nucleic acid test and at home kits also. So then we come to confirmatory test. If the test screening test is reactive, confirm with second RDT based on different antigen principle, like depending upon there can be other tests to confirm. Then we have Western blot, which is rarely used now, but confirmatory in some setting, and it is ultimately the used to be the gold standard for HIV. Then we have PCR tested for HIV RNA, used specially for infants less than 18 months and when serology is difficult to interpret. Additional lab test, additional baseline test at diagnosis. Once the HIV is confirmed, additional tests include CD4 count, which shows immune function, HIV viral load, Myers virus in the blood, complete blood count, liver and kidney function test, hepatitis B and C screening, and TB screening by gene expert or chest X-ray. Now we come to management of HIV. We have management like antiretroviral therapy, which is also known as ART. Initiate immediately after diagnosis. First line regimen include tenofovir, lamivudine, and dolutegravir. So it is also known as TLD, lifelong therapy. And then we can have monitoring of CD4 count every 6 to 12 months and viral load every 6 months. So this is now we will explain the art in detail. Antiretroviral therapy art is a lifelong and aims to suppress viral load to undetectable level, restore and preserve immune function, prevent AIDS related complication, and prevent HIV transmission. First line art regimen recommended by WHO are, as I explained, TLD regimen, which have these three drugs, and the method is once daily, highly effective, and there are very few side effects. And there are then alternative for patients with kidney issues. Then we have second line art regimen, and they are used if first line fails based on viral load monitoring. And then we have third line or salvage therapy, reserved for multi-drug resistance, advanced agent depending on drug on resistant testing. Okay, so monitoring of HIV treatment is very important. Viral load is done at 6 months, then at annually. CD4 count, if available, especially in advanced disease, is very important. Adherence counseling on every visit. Monitor for drug toxicity. So we do kidney, liver test, and testing for anemia. Prevention and supportive care, opportunistic infection prevention, cotrimoxazole prophylaxis if CD4 count is less than 350, isoniazid prevention therapy for TB, fluconazole if recurrent fungal infection is present, adherence and psychosocial support. These are one of the most important aspects for management by counseling, nutritional guidance, mental health support, and reducing stigma and ensuring confidentiality. So now we will apply the three levels of prevention for HIV. It will start with primary prevention, secondary prevention, and tertiary prevention. So at primary prevention, we have the aim to prevent new infections before exposure occurs. It can be ensured by safe sexual practices, condom use by male and female condoms, limiting number of sexual partners, regular STI screening and treatment reduces HIV transmission and risk factors. Then we have prevention in high risk group, pre-exposure prophylaxis for at-risk individual, harm reduction program for people who inject drugs, like needle and syringe exchange or opioid substitution therapy. Then we have blood safety, mandatory screening for all donated blood and safe transfusion practices, avoidance of sorry avoidance of unnecessary drug injections, use of disable syringes, like you might have noticed, which are commonly being available in markets now, especially for 3cc and 5cc syringes, prevention of mother to child transmission, early antenatal screening, art for all HIV positive pregnant mothers, safe delivery practices, and infant prophylaxis. Health education and awareness, community awareness on HIV modes of transmission, anti stigma and anti discriminatory campaigns, and youth focused sexual health education. Now we come to secondary prevention, with aim is to early detection and early treatment to reduce complication and transmission. Screening and early diagnosis by HIV rapid test, ELISA screening, provider initiated testing in high prevalence setting, and screening in antenatal clinics, TB clinics, STI clinics. Early initiation of ART by test and treat strategy, ART for all diagnosed persons, reduces viral load and thus reducing infectivity. Surveillance reporting and partner notification, strengthening case reporting and monitoring, contact tracing and partner notification, follow up testing for exposed partner. Preventing opportunistic infections, cotrimoxazole prophylaxis, isoniazid preventive therapy in TB endemic areas, vaccination of HPV, pneumococcal as appropriate, risk reduction counseling by after diagnosis, and guidance on safe sex, adherence, and disclosure. Now we come to tertiary prevention, with aim is to reduce disability, improve quality of life, and prevent complication in people living with HIV/AIDS. Long-term clinical management by lifelong ART with viral load monitoring, management of ART side effects and resistance, regular CD4 monitoring to assess immune recovery, management of opportunistic infections and AIDS condition, treatment of PCP pneumonia, cryptococcal disease, TB candidiasis, cancer screening by Kaposi sarcoma, lymphoma, and cervical cancer. Rehabilitation and psychosocial support, which include counseling for mental health, depression, stigma, social support group, occupational and nutritional rehabilitation. Preventing disability and further complication by preventing Swiss wasting syndrome, prevention of neurological complication, long-term adherence support to maintain viral suppression. And finally, we have community and family support, home-based care program, caregiver training, and reducing stigma to improve integration. Now we come to the burden of disease. First, we will cover the global burden of disease. There are about 38.4 million people living with HIV according to 2023 studies. 1.5 million of them new infections are being added. 650,000 deaths due to AIDS related illnesses annually worldwide. These are the recorded numbers. And the highest burden is present in sub Saharan Africa. 70% of the global cases are there. Key drivers globally include low condom use, gender based violence, stigma limiting testing, low art coverage in some regions. So, this is the share of population living with HIV according to 2023 stats. And these are the adults age 15 to 49 living with HIV. As you can see that in South Africa and some parts of others, southern part of Africa, there are the population of HIV include above 20% of all individual. So this is basically a small region in South Africa where every 1 in 5 person is having HIV, and even in other this dark red is showing like 10 to 20% of the population of the whole country is affected by HIV. So these are very big numbers. In Pakistan, as you can see, the number is between zero point 0.2 to 0.5. I think it's actually zero point 0.3 exactly, but we will see it in later slides. So this is the current situation. And this is the showing the graph is showing the HIV or deaths averted by antiretroviral therapy in 2023, estimated annual number of deaths from HIV/AIDS, and the estimated number of deaths averted by antiretroviral therapy. These are based on treatment access, treatment efficacy, surveillance data, and epidemiological modeling. So, as you can see in Pakistan, about 2,000 to 5,000 deaths were averted by therapy. And in some African countries, these are above 100,000 even, only in 1 year alone. Again, this is showing the same data in the graph form. As you can see, it starts with 1990 with the HIV or AIDS related deaths, which starts in 1990 at 500,000. And then in early 2000, it peaks at 2 million. In 1 year, there were 2 million deaths from HIV in early 2000. And then we have the art therapy, and it starts averted. The deaths are being averted. Blue color is the deaths which are being prevented due to art therapy, and so we have a decline in the HIV AIDS death, which is the actual number is by the red color. So we have very less number of HIV deaths specifically due to therapy. Otherwise, the numbers would have been still above 2 million. So this is the. And now again, this is showing the death rate from HIV/AIDS in 2021. As you can see in Pakistan and India, the similar death rate is about 1 to 5 individual per 100,000 of the people. So now we come to national burden. Pakistan faces a significant and growing burden of HIV/AIDS with estimated 330,000 people living with HIV as of September 2025. The epidemic is largely concentrated within key population and is expanding due to a complex mix of social, economical, and health-related factors. So for Pakistan, the key stats are there are 330,000 people living with um, HIV. Officially registered cases are 81,847, which are about 25% of the estimated total. And the people on antiretroviral therapy are even less, which is only 58,622. And general population prevalence is still very less, it's less than 0.1%. Pakistan, unfortunately, has the second fastest rate of AIDS breakdown in the Asia Pacific region and has been registering around 20,000 new cases annually in recent years. So, the key population in Pakistan for Pakistan is um, people who inject drug 38.4%, transgender sex worker 7.5%, male sex worker 5.6%, and men who have sex with men 5.4%. So, for Pakistan, the national burden of HIV is due to unsafe healthcare practices, widespread use of unsterilized needle and syringes, particularly by untrained local practitioners or quacks. Social stigma and discrimination. A significant barrier to control is the intense social stigma surrounding HIV. Low awareness and education. A lack of awareness about transmission routes and prevention methods across the general population contributes to the spread. Unsafe blood transfusion. Inadequate screening of blood transfusion has historically been a transmission route, though efforts are being made to improve safety protocols. For recent updates, we have World's AIDS Day is celebrated on 1st December every day, and for 2025, the theme is overcoming disruption, transforming the AIDS response. Then, for this year, on 1st December, WHO joins partners and community to commemorate World AIDS Day 2025 under the theme Overcoming Disruption, Transforming the AIDS Response, calling for sustained political leadership, international cooperation, and human rights centered approach to end AIDS by 2030. After decades of progression, HIV response stands at crossroads. Life-saving services are being disrupted and many communities face heightened risk and vulnerabilities. Yet, amid challenges, hope endures in the determination, resilience, and innovation of communities who strive to end AIDS. So in 2024, there were 40.8 million people living with HIV globally. Approximately 630,000 people died from HIV related deaths, and about 1.3 million people acquired HIV in 2024. So, for WHO, the Global Fund, and UN AIDS all have global HIV strategies that are aligned with the SDG target 3.3 of ending the HIV epidemic by 2030. By 2025, 90% of all people living with HIV should have a diagnosis, 90% of whom should be taking lifestyle antiretroviral treatment, and 95% of people living with HIV on treatment should receive a suppressed viral load, excuse me, for the benefit of the person's health and for reducing onwards transmission. So it is 95%, 95%, and then 95%. But in 2024, these percentages were 87%, 89%, and 94%. So it means that 87 of the people actually who have HIV knew their status, 77% of the people were receiving antiretroviral therapy, and 73% had suppressed viral loads. From antiretroviral to curative therapies, current development in HIV treatment and prevention. This is an article which was published in European Journal of Medical Chemistry on 15th December 2025. It first of all is telling how antiretroviral therapy, although very effective in viral suppression, is still complicated and it is difficult to take it for lifelong due to drug-related toxicities, adherence barriers, and resistance to latent viral reservoirs. Gene-based approaches, including CRISPR and Cas9 editing, stem cells transplantation, and reserving or latency silencing strategies are being explored to directly target and eliminate viral reservoirs. Parallel efforts in immunotherapy, therapeutic and preventive vaccine, pre-exposure prophylaxis, and treatment as prevention are expanding the preventive and therapeutic strategies. And now we have on 14th July 2025, sorry, WHO recommends injectable lenacapavir for HIV prevention on the IAS 2025 conference. It is also known as LEN, an injectable medicine which can be given twice a year only as an additional pre-exposure prophylaxis option for HIV prevention in a landmark policy that could help reshape the global HIV response. The guidelines are being issued at 13th International AIDS Society Conference IAS 2025 on HIV science in Rwanda. It is the first twice yearly injectable PrEP product, offers a highly selective, highly effective, long active alternative to daily oral pills and other short acting options. So now we come to multiple choice questions. A 24-year-old man presents with fever, rash, lymphadenopathy 3 weeks after unprotected sexual contact. His symptoms resolved spontaneously. Which test is most appropriate for diagnosing HIV at this early stage? Western blot, fourth generation HIV ELISA, CD4 count, urine HIV antibody test, or HIV-2 serology only?
A.
So we will apply the for diagnosing early stage ELISA for HIV ELISA is better. A 35-year-old woman with confirmed HIV has chronic diarrhea for 2 months, severe weight loss, and oral candidiasis. Her CD4 count is 140 cells per microliter. Which WHO clinical stage best fits this presentation? Stage 1, stage 2, stage 3, 4, or cannot be staged without viral load?
D.
Um, Basically, it is having condition like chronic diarrhea and severe weight loss for now. And yes, the answer should be D. Yes. Then I have during an outbreak investigation, a team finds that a cluster of HIV infections occurred among individuals who received injections from a single informal clinic. Which link in the chain of transmission was primarily responsible? Susceptible host, portal of entry, reservoir, mode of transmission, or agent virulence?
D.
Yes, mode of transmission. Yes, it is mode of transmission. During a community awareness session, participants expressed fear that HIV may spread through mosquito bites or sharing food. As a public health official, what is the most evidence based explanation you should provide? HIV cannot survive outside the body for more than 48 hours. Mosquito do not inject infected blood into another person when biting. HIV transmission requires high viral load in casual contact. HIV transmission occurs only through breast milk and needles. Foodborne transmission is rare but possible in crowded settings.
B.
Yes. Mosquito do not inject infected blood into an other person while biting. A public health resident is analyzing Pakistan HIV data. She notes that registered cases are far lower than estimated cases, 81,000 versus 330,000. What is the most important implication? HIV is close to eradication. Art resistance is the major barrier. Significant underdiagnosis and poor surveillance. Majority of patients have HIV too, or HIV transmission has shifted to vector-borne patterns.
C.
Yes, significant underdiagnosis and poor surveillance. A nurse sustains a needle stick injury from an HIV positive patient. What is the first step in management? Initiate art for life. Start PEP within 72 hours. Perform CD4 count. Wait for symptoms to appear. Begin TB prophylaxis.
B. B.
Yes, start PEP within 72 hours. Pre-exposure profile. A 45-year-old man with known HIV presents with greater than 10% weight loss in 2 months and chronic diarrhea for 5 months. No other cause is identified. Which condition is most consistent with this clinical picture? Acute HIV seroconversion, immune reconstitution, inflammatory syndrome, HIV wasting syndrome, stage 2 HIV infection, or lipodystrophy from ART. Yes, it is HIV wasting syndrome when the weight loss is greater than 10% of the body weight. NGO starts a program providing auto-disabled syringes and mandatory blood screening in hospital. Which level of prevention does this represent? Primordial, primary, secondary, tertiary, or rehabilitation? Yes, it is primary. Patient started on TLD regimen 6 months ago. He feels well and reports good adherence. According to WHO recommendation, which investigation should be prioritized now to assess treatment success? CD4 count, viral load, CBC, RPR for prophylaxis or chest X-ray?
A.
No, as the patient is feeling good, so we will go for viral load. So it is B. So depending on the patient's condition. So this is the YouTube link where the video will be uploaded, and thank you very much for listening.
Dr. Taimia, it was a very good presentation and
Thank
a